This is Dr. Hani Arif, the director of the Neuro Academy program of Ain Shams, a professor of neurology at Ain Shams University. We had a successful program last year with so many waves of eminent speakers. I think most of the people who attended the sessions get benefited from the educational material and the wealth of knowledge during this program. I will announce the kickoff of the program this year. We will start with a wave about headache, and we are honored to have with us Professor Pascal from Belgium. He's one of the eminent speakers and figures in the headache field. And the moderator of this session will be Dr. Ramez, Professor of Neurology at Ain Shams University, and he is the head of the headache and general unit in the neurology department. Please, Professor Ramez, the mic is yours.
Thank you very much, Professor Hani Arif, and also thank you, Professor Azza Abdel Nasser. And yes, we are glad to start this year's wave with headache. Headache education has been taking off in the past couple of years, and it's really a pleasure to have with us some of the most eminent speakers and professors in headache around the world. And today, our speaker is Dr. Pascal Prout, who's one of the most prominent neurologists in headache in Europe. He's been teaching headache around Europe in many countries, and he is he's based in Belgium at the University of Ghent. He also teaches in the Netherlands and in the headache center there, and he teaches also EMG, electroneuromyography, in several places in the Netherlands, Belgium, and around Europe. So we're glad to have him. Of course, he's a member of the Dutch Association of Neurology and, of course, the Dutch Association of the Headache Centers. So we're glad to have him today, and he will speak to us about the role of anti-CGRP medications in the management of headache in a holistic approach. I'll leave him to introduce the topic, of course. So welcome, Professor Prout, and we're happy to have you with us today. Please.
Okay. So, good evening, dear colleagues. My name is Pascal Prout. I am a clinical neurologist. I educate clinical electromyography in University of Ghent in Belgium. I run a multidisciplinary headache center in the Netherlands. In the center, we work together with administrators, with 2 headache nurses, with a physiotherapist, and 2 psychologists. Most patients consulting the headache center suffer from chronic primary headaches. Monoclonal antibody-based therapies targeting the CGRP pathway are, as you know, an emerging class of migraine preventive therapies. FDA approval in the United States was first granted to irenicimab in 2018, followed by fremanizumab and galcanezumab in the same year. All 3 are dosed once in a month. Eptinezumab is approved in 2020. So I would like to thank the organization committee for the invitation. I would like to thank the sponsor to support this lecture as part of headache education. The sponsor is dedicated to enhancing migraine medical treatment with galcanezumab or Emgality. Okay, I want to go to next slide. I strongly believe in a multidisciplinary treatment of chronic migraine. As migraine is often an expression of stress experienced by the body, cognitive behavioral treatment during your headache consults or with a psychologist has definitely its merits. I will talk about this topic during another occasion, of course, in combination with the medical treatment as usual. Implementation of ACT, acceptance and commitment therapy, brings superiority to the treatment you offer your patients. Meanwhile, the medical treatment is and remains very important. Restore the daily functioning at work, at school, and at home is a primary priority for acute and preventive treatment among the individuals with migraine. So the focus of today's talk, as you can see here, is the positioning of the CGRP monoclonal antibodies in your real-world daily clinical activities. I would like to argument this positioning based on epidemiology, based on pathophysiology of migraine, based on the clinical trials that are used for approval of those monoclonal antibodies. And as well, we're going to talk about possible side effects. So headache disorders are among the most common and disabling disorders worldwide, accounting for more disability-adjusted life years than all other neurological disorders combined. This burden is largely attributed to migraine, which is the third leading cause of disability in people under the age of 50. Migraine is one of the most common debilitating neurological diseases worldwide, third in prevalence, second in disability. Migraine affects women 3 times more than men. Overall, about 12% of the population suffers from migraine worldwide. So these are the criteria written down in the International Classification of Headache Disorders, third version for episodic and chronic migraine. I think this is very easy for all the audience to understand, but just to repeat that episodic migraine is migraine that happens a couple of times in a month, while chronic migraine is migraine that appears at least 8 days in a month in a headache diary of more than 15 days per month. So the symptoms need to meet the criteria are very clear. However, apart from the symptoms listed here in the criteria, there are a lot of other bothersome symptoms as showed on the following screen. All these symptoms, they cause a huge burden of disease. We have the prodrome phase, we have the aura phase, then we have the headache phase, and we have the postdrome phase. What I want to stress is that a migraine attack is much more than just the criteria mentioned in the International Classification of Headache Disorders. We talk about a lot of bothersome symptoms. As you see here, several symptoms may be associated with migraine. The symptoms may overlap between the various stages of a migraine attack. Clinical manifestations, they vary among patients and in individual patients over time. So migraine presents in a spectrum with clinical symptoms that vary along a continuum from episodic to chronic migraine. This transformation from episodic to chronic migraine happens in approximately 2.5% of the patients with episodic migraine annually. What I want to stress on this slide is that migraine is a dynamic, fluctuating disorder. Other neurological diseases like dementia, multiple sclerosis, Parkinson are progressive neurological diseases requiring chronic medical treatment. Migraine is not a progressive neurological disease, but it's a fluctuating disorder. Migraine may worsen over the time with, of course, increased headache frequency. And apart from the knowledge that migraine is a fluctuating disorder throughout life, there are several risk factors for this transformation to chronic migraine, such as frequency of headaches, previous head or neck injuries, and genetics. Recent studies conclude that migraineurs, for example, with mild traumatic brain injury had more migraine-related disability and were more likely to experience dizziness, vertigo, and other bothersome symptoms. They have moderate to severe anxiety and depression very often. Other risk factors are comorbidities like, indeed, depression, anxiety, obesity, asthma, and snoring. We talk also about stressful events and caffeine. And let us not forget that medication overuse is considered as an important risk factor for the transformation from episodic migraine to chronic migraine. All of these mentioned modifiable risk factors may provide targets for intervention. Chronic migraine is associated with much more disability than episodic migraine, not only because of these bothersome symptoms, but also because of the socio-economic burden of disease. People have difficulties to continue their work, have difficulties to continue their social life. Also, the relations at home are often under stress because of the headaches. So the chronic migraine patients reported less overall satisfaction with their care and with access to the care, and advice is needed when compared to those with episodic migraine. Patients with chronic migraine report a low rate of prevention medication use. So there is a huge unmet need for chronic migraineurs, and there's a huge unmet need to prevent episodic migraineurs to transform to chronic migraineurs. Education of the caregivers, education of the patients, as well as improved access to medication are important worldwide. And this is also the reason why I'm very happy to talk with you about headache this evening. So migraine has an important societal impact. Patients with migraine, they can experience decreased quality of life due to the headache frequency, due to the headache severity, due to other variable symptoms that they experience. The individual and societal burden of migraine can be substantial as migraine prevalence peaks during the most productive working years. I told you the very high incidence beyond the age of 55. So migraine has a global negative impact on overall life, on cognitive and emotional health, work, family, and social life. Migraine contributes to isolation, to frustration, to guilt, to fear, to avoidance behavior, and for sure a stigma within the family, within their friends group. A greater understanding of this deep burden of this chronic neurological disease is needed to effectively target and treat what is most important to those living with migraine. Newer drugs, we are very happy that they're there, are evaluated in pivotal clinical trials. Pivotal trials means that those trials are very compulsory for approval on the market. For migraine treatment, a primary endpoint in those trials is, of course, the decrease of migraine headache days. But aware of this huge burden of disease that is mentioned on this slide, a lot of secondary endpoints are important and convincing. Secondary endpoints of the same pivotal trials. What do I mean? Secondary endpoints is, for example, change in migraine functional scales or change in patient-reported outcomes. Indeed, the doctors and the patients, they should be convinced that life quality gets better with appropriate treatment plans. We understand why several endpoints in the trials are so important. We will focus on this later on in this lecture. So, to conclude about the burden of disease and about epidemiology, migraine remains an underdiagnosed and undertreated disorder in your daily practice. It is estimated by the World Health Organization that only 40% of patients with migraine are professionally diagnosed. 44.6% of the responders who were diagnosed with migraine discontinued their acute medication within a year. only 12% of the respondents surveyed who were diagnosed with migraine were on preventive medication, only 12%. Over 40% of those preventive users had a history of previous preventive medication failure or of switching treatments. So the most common causes of discontinued prescribed acute and preventive medication include decreased efficacy and adverse reactions. We will continue on this. But those numbers that are mentioned here in red, over here, those numbers are very important. We want to improve the rate of diagnosis of migraine. We want to improve the multidisciplinary treatment for chronic headaches. Better education of the patients, pharmacists, and also the doctors is necessary worldwide. Access to the best medical treatment helps to decrease the chronic burden of disease. We are here tonight to discuss the position of an approved, good medical treatment for episodic and chronic migraine. So after this epidemiology and burden of disease, let's hand some words about pathophysiology of migraine. So migraine is based on several parts in its pathophysiology. First is the cortical spreading depression. The cortical spreading depression is an abnormal brain activity associated with visual aura and other migraine-related symptoms. Second, there is very important, the activation of trigeminal-vascular system. It regulates the pro-inflammatory and pain-inducing neuropeptides. It has a central role in migraine pathogenesis and migraine headache. Third is the dysfunctional pain control center, which is a potential parallel mechanism in migraine. This dysfunctional pain control center may cause the brain to give a misinterpretation to normal stimuli in patients with migraine. So about this cortical spreading depression, a few words. The cortical spreading depression originates in the occipital region of the brain. It is a slowly propagating wave of altered brain activity that involves dramatic changes in neuronal, glial, and vascular functions. The cortical spreading depression precedes migraine symptoms and plays a very important role in migraine aura and other migraine pathophysiology. However, the definitive effect of cortical spreading depression in migraine has not been fully established. And so it is with the other parts of the migraine pathophysiology as well. But then there is the activation of the trigeminal-vascular system. The trigeminal-vascular system, nociceptive system, plays a key role in the pathophysiology of migraine, regulating cranial vasculature and innervating the pain-sensitive structures of the head, including the meninges and the large cerebral arteries. The cranial meninges is innervated with nociceptive afferent neurons of the trigeminal vascular system. During a migraine attack, activation of these trigeminal nerves leads to a release of mediators, neurotransmitters around the vessels in the meninges. This results in underlying processes associated with migraine, some kind of neurogenic inflammation, there is vasodilation, nociceptor activation, and there is propagation of a pain response. So the trigeminal vascular system, with its efferents and its efferents back to the different areas in the brain, is very important in the pathophysiology of migraine, apart from cortical spreading depression. So the trigeminal vascular system plays an important role in migraine. It is activated during the headache phase. There is a sensory nociceptive input from meninges and intracranial vessels. And there are two important types of nociceptive neurons, the non-myelinated, the C fibers, and the thinly myelinated, A delta fibers. Why is this important? Because the different therapies like botulinum toxin and the CGRP antagonists, they work on different fibers. So the trigeminal nociceptive efferents consist of A delta and C fibers. The A delta fibers, which are very medium diameter and thinly myelinated, they transmit the acute pain, while the C fibers, which are small diameter and unmyelinated, they transmit the lingering pain, such as aching and burning. The cell bodies of these efferent neurons from the trigeminal ganglion, they transmit the sensory signals from the periphery, from the meninges, to the nociceptive dorsal horn laminae of the spinal trigeminal nucleus. Ascending fibers from this spinal trigeminal nucleus, they transmit nociceptive signals to multiple regions of the brain, including brainstem nuclei, hypothalamic nuclei, and basal ganglia. And these projections to a wide area of cortical areas likely give rise to many of the associated symptoms of migraine, such as transient amnesia, cognitive decline, phonophobia, photophobia, and expressive aphasia. So very important is this trigeminal vascular system with the efferents coming from the meninges, from the vessels, where there is the neurogenic inflammation, going back to the deep nuclei, and from this deep nuclei in the brainstem, spreading to a lot of areas throughout the brain, giving rise to a lot of different symptoms. So third is the dysfunctional pain control center. The brainstem has modulatory roles in the development of central sensitization in migraine. The repeated activation of pain pathways leads to increasing sensitivity of trigeminal neurons in the brainstem. There is a dysfunction of pain modulation which enhances central sensitization phenomena, contributing to acute allodynia and headache persistence. Different neurotransmitters and neuropeptides may play a role in migraine. They interact with each other. Here are some examples. Widely studied are, of course, the serotonin, the CGRP, substance P, the vasoactive intestinal peptide, the pituitary adenylate cyclase activating polypeptide, PACAP, and glutamate. Cortical spreading depression, for example, is a glutamate-dependent process. Migraineurs, they have a high level of cortical glutamate. Glutamate is the exciting neurotransmitter in the ascending trigeminal pathway, the efferents. CGRP modulates the glutamatergic transmission. Recently, during European Headache Federation 2 weeks ago or 3 weeks ago, we learned about the importance of lately studied receptors. For example, there is the delta opioid receptors, which are of any importance. It inhibits the CGRP signaling pathways and decreases the release of CGRP. Activation of these delta opioid receptors, they inhibit cortical spreading depression. They diminish the migraine-related pain called allodynia. Medical treatments, they focus on those receptors. So this is the reason why I mentioned the importance of these receptors. Topiramate, for example, Topamax, is, for example, antagonist of the kainate receptor, which is present through the whole trigeminal pathway. Botulinum toxin blocks the release of glutamate and CGRP from the trigeminal ganglion. Transcranial magnetic stimulation modulates the cortical glutamatergic excitation. Let us focus a little on serotonergic receptors, because many of the neurons in the trigeminal vascular system are serotonergic. The 5-HT1 receptor subtypes are the most studied serotonin receptors in migraine. Abortive medical medication is based on this scientific work. So serotonin and its 5-HT1 receptors, many of the neurons in the trigeminal vascular system are serotonergic. The 5-HT1 receptor subtypes are the most studied serotonin receptors in migraine. We have 5-HT1 receptors, which exhibit a diverse expression in the trigeminal vascular system. And here are listed different functions of 5-HT1B found on neurons and vascular smooth muscle. 5-HT1F as well as 1D are found on neurons, Then we have 1A and 1E are expressed in the central nervous system and are targets for some anti-migraine compounds. The role in migraine is not fully understood, but for example, for the triptans and the working mechanism of the triptans, those receptors are very important. In fact, it's all about neurotransmitters. So there is a growing understanding of this specific 5-HT1 agonists. The 5-HT1 agonists, including the triptans, were developed for the acute treatment of migraine. The triptans induce vasoconstriction in arteries and veins. This is most likely by selective activation of 5-HT1B. But it's not only about vasoconstriction. More important in the pathophysiology of migraine is this neurogenic inflammation, is this trigeminal-vascular nucleus and pathway. So we are talking about receptors as well as neurogenic inflammation, more than the vasoconstriction, which was very important to promote the triptans 20 years ago. Like here's a short graph of how elatriptan was promoted 20 years ago after the FDA approval in 2002. A newly introduced acute treatment is serotonin 5-HT1F agonist lasmoditan. So for the people who have really a lot of side effects on the triptans as acute treatment, we can switch to the newer agonists like the GPANs or the ditans like lasmoditan. So there is a growing understanding of the specific agonists, and it's much more than just a vascular dysfunction. Changes in neuronal activation are the primary contributor to migraine rather than just cranial vasodilation. The peripheral and the central nervous system dysfunction plays a very fundamental role in migraine. So what is CGRP? CGRP, or calcitonin gene-related peptide, is a small neuropeptide with a wide distribution in both peripheral and central nervous system. CGRP is important. It regulates the vasodilation, it regulates neurogenic inflammation, it regulates pain transmission. CGRP is one of the most abundant neuropeptides within the trigeminal vascular system, and it has a very central role in migraine. It is expressed in about 50% of the neurons in the trigeminal ganglia. Of course, CGRP is present in all organ systems. It plays a role in inflammation, it plays a role in gastrointestinal motility, it regulates the blood flow, and it's also involved in a lot of other pain conditions. So we have to take care about possible short and long-term side effects. We will talk about this at the end of the lecture. Luckily, the CGRP does not cross the blood-brain barrier in clinically significant amounts, so there is a lack of central nervous system-related adverse events, such as somnolence and cognitive dysfunction. But remember from this slide that it is present in all organ systems throughout our body. So the CGRP role in migraine is clear because increased CGRP levels correlate with the onset and the pain intensity in migraine attacks. The CGRP role in migraine is clear because, second, the infusion of CGRP has been shown to induce migraine-like attacks in susceptible patients. CGRP role in migraine is very clear because of this third reason. The CGRP levels may return to normal following cessation of migraine headache. And CGRP is associated with photophobia. So there is a clear, defined role of CGRP in migraine. So the trigeminal vascular system and CGRP, it combines different actions, as we can see here. We have the premonitorous symptoms and the hypothalamic activation. There is the activation of the trigeminal vascular system, the nucleus caudatus, and also the trigeminal ganglion. And there is the activation of the C fiber meningeal nociceptor, which releases CGRP in the dura. So CGRP is very important for the efferents, is very important in the trigeminal system and the nuclei, and is also important in the premonitory symptoms and the activation of the whole pain pathway. After this pathophysiology piece, after these receptors, let's talk a little bit about, first of all, the abortive treatment, the acute treatment. The goal of the acute treatment includes following. You should have a rapid and consistent freedom from pain and associated symptoms, especially the most bothersome symptoms, without any recurrence of the pain. We should have a restored ability to function. We should have a minimal need for repeat dosing or rescue medications. There should be, with this acute treatment, an optimal self-care and a reduced subsequent use of resources like emergency room visits or diagnostic imaging. And of course, they should have minimal or no adverse events. And last but not least, the healthcare cost considerations are very important goals of optimizing these acute, but also the preventive medical treatment. So for acute treatment, we like to use evidence-based treatments. Guidelines could be based on evidence if possible. Sometimes, and this you will experience later on in the lecture, sometimes the guidelines are based on expert opinion, which makes them a little weak in very important questions. Guidelines for acute treatment include the use, as you see here in step 1, the use of a symptomatic therapy like non-steroidal anti-inflammatory drugs, non-opioid analgesics, acetaminophen, or caffeinated analgesic combinations for mild to moderate attacks. But as step 2 here mentioned, we use migraine-specific agents like triptans when these former other analgesics are not satisfying. Newer molecules after the triptans are the small molecule CGRP receptor antagonists, the GPANs, or the selective serotonin receptor agonists, the dietans. The dietans and the GPANs, we don't know them yet on the European market, but of course they have already got some FDA approval and they're well tolerated in American migraineurs. So a long time ago, a meta-analysis of 6 triptans showed a similar headache relief for all those triptans at 2 hours, showed a similar proportion of pain-free patients at 2 hours after intake, and a similar consistency. Triptans were very safe, as long as they were not used in patients with cardiovascular disease or major risk factors. Since there were no clinically important differences in coronary vasoconstriction effects, no triptan is demonstrably safer than the others. This meta-analysis has been published in 2001 for the triptans. We are still waiting for any meta-analysis for the CGRP monoclonal antibodies. It's still a bit too early. So, but the British Association adds some further details for the guidelines for acute treatment. In our headache center, we are used to associate an antiemeticum like domperidone or metoclopramide before intake of the analgesic. The antiemeticum decreases the nausea and vomiting, which are severe bothersome symptoms. And of course, the treatment itself with the triptan can increase the nausea and vomiting. Second, they improve the efficacy of the triptans. So, and then we have the other guidance of note, which is very important. We should take the triptans very early in the attack. A lack of response to one triptan does not predict response to another, but we can change the triptans, and we use an alternative triptan after more or 2 failures with the first one. Let's talk about another very important stuff, is the medication overuse headache. Medication overuse is defined as an intake of more than 15 days per month during more than 3 months of simple analgesics, or is defined of more than 10 days per month for more than 3 months of triptans, or more than 10 days per month a combination therapy with triptans, ergot derivatives, analgesics, and opioids. Ergotamine overuse remains common in a lot of countries worldwide, while prophylactic medicine is still underutilized. So more education on ergotamine overuse headache is needed to improve the awareness. A lot of patients depend on self-medication and appear to be inadequately treated. Migraine-specific prophylactics are inefficiently used and adherence is poor. So this is the reason why medication overuse headache happens so often. It has been associated with a dysfunctional brain in the pathways controlling the pain modulation, controlling the areas of sensory discrimination, controlling the regions involved in cognitive pain processing, and in those controlling addiction. Patients with episodic migraine overtaking acute medication are, as I told you before, risk to transform to chronic migraine. The disability of patients with chronic migraine is much higher than in, for example, low-frequent episodic migraine. A critical step in the longer management of migraine is to prevent this medication overuse headache. Yes, the abortive treatment is very important, but we should look for the best abortive acute treatment so patients are not falling in this medication overuse headache. Very limited evidence is available regarding the treatment strategies, which are mostly based on non-controlled studies, the treatment strategies for this medication overuse headache. However, prophylactic therapy, preventive prophylactics, is recommended for patients with medication overuse headache. It aims to reduce the frequency, reduce the duration and the severity of the migraine attacks. And the therapy also enhances the responsiveness to acute therapy. So after this acute treatment, after having discussed for short the medication overuse headache, we are moving on to the prophylaxis. Preventive therapy is typically recommended in patients with a high headache frequency. In addition to the headache frequency, other parameters to consider for prophylactic treatment include severity and disability of migraine, headaches that are not responding very well to abortive treatments, headaches that occur in the presence of other migraine conditions or comorbid disorders like depression. Patients who might also benefit from these prophylactic approaches are those who overuse prescription or over-the-counter abortive agents, as we just explained, or who fail to respond to non-drug therapies like meditation, cognitive behavioral therapy, and so on. And also the patients who are unable or unwilling to comply with treatment recommendations are very willing to get some more knowledge about this prophylactic treatment. So we should offer prophylaxis when migraine attacks are not well controlled with acute treatment alone. But you have to look at your individual patient, at his or her story. Maybe 2 attacks of 3 days each is very, very boring. It's very annoying during professional and social life. Other people, they can afford 8 milder headache attacks before the preventive treatment should be considered. So with indications for the preventive therapy is the impaired headache-related quality of life, the disability due to attacks of more than 2 days per month. If the acute therapy has been optimized but still does not prevent disability or cannot be tolerated, if there is a severe risk of overuse, or if the patient is willing to take daily medication just to decrease the headaches. So several ideas, several reasons when and why we should offer preventive treatment to the patients. As with acute treatment, individualized patient education and lifestyle modification recommendations are very important in preventive treatment plans. not only the medication is important, but patients should be, first of all, instructed about the identification and the minimization of exposure to migraine triggers, as well as the benefits of proper nutrition, 3 meals a day, regular physical exercise, adequate hydration, a proper sleep, a stress management, and maintaining a migraine diary. The use of evidence-based treatments is essential to the success of migraine prevention. And here on this slide are listed preventive pharmacological treatments that are really effective. The European Headache Federation advises to use beta blockers, amitriptyline, and topiramate as preventive therapies in episodic migraine. As you know, propranolol is classified everywhere as level A drug. It is established as effective for migraine prevention. Beta blockers are competitors in the central nervous system of the catecholamines. Both bind the beta-1 and beta-2 receptors. The second is amitriptyline. Amitriptyline is a tricyclic antidepressant. It is thought to prevent migraine by inhibiting serotonin and norepinephrine reuptake and maintaining serotonin levels. The third is topiramate. Topiramate is an antiepileptic drug that is approved for migraine prevention with level A evidence of efficacy. Topiramate has multiple targets, as I told before. One of them is the kainate receptor. But other targets is the voltage-activated sodium channel, the high-voltage-activated calcium channel, the GABA receptors, and so on. Candesartan is a angiotensin II receptor blocker, leading to vasodilation and hypotension. Exact working mechanism of this migraine prophylaxis is unknown. It is off-label, but very frequently used in several countries, and for sure in the Netherlands, it is one part of the guidelines of treatment for prevention and migraine. Valproate is another antiepileptic drug. It is an antagonist of voltage-dependent sodium channels, and it reduces the excitatory transmission by increasing brain GABA concentrations. Flunarizine is a calcium channel blocker. Factors in the optimal drug selection for your patient for the best preventive treatment are evidence of efficacy, of course, your medical professional experience as a caregiver. We also consider tolerability. We, of course, consider the headache subtype. Is it episodic or chronic? Concomitant medications and eventual contraindications for one or more of these preventive medications. So we consider the patient preference and coexistent illnesses. We consider pregnancy or the potential for pregnancy and the best choice of treatment. And although evidence can narrow the range of therapeutic options, it does not replace clinical judgment. The most important is clinical judgment. Preventive treatment plans must be designed to meet the needs of the individual patients with migraine. For example, among those with a history of at least 8 migraine headache days, if the medical risk from a trial of 2 or more established preventive treatments outweighs the possible benefits, well, patients should be allowed to access whatever treatments that are deemed medically necessary. They should be allowed to go to another treatment which is not in the guidelines, to start acupuncture, to start cognitive behavioral therapy. Meeting the individualized needs may also involve combining older and newer treatments as well as complex or non-traditional approaches. So, okay, thank you very much for the guidelines, but we should tailor them for our patient that is sitting in front of me during every consultation. Combining different preventive drugs to optimize the migraine prophylaxis is not my favorite. It is not done in our headache center because of the drug-to-drug interactions that we fear, and because it is difficult to understand which of the prescribed drugs is really effective if you take 2 or 3 or more preventive drugs. Also, the UK NICE guidelines suggest that preventive therapy should be initiated at the lowest effective dose, with slow increases topiramate, 25 milligrams, increasing in 25 milligram steps. Propranolol, we start with 80 milligram and gradually increasing to a maximum of 240. Amitriptyline, start with 10 milligram, gradually increasing to 150, which is already a very high dose. I don't titrate higher than 50 milligrams. But they should be initiated at the lowest effective dose with slow increases until effective or intolerable adverse events occur. An adequate drug trial should be followed for a minimum of 8 weeks at a target therapeutic dose before lack of effectiveness can be determined. If there is no response to treatment after at least 8 weeks, switching preventive therapies is recommended. Patients with a partial response should be counseled that cumulative benefits may occur over 6 to 12 months of continued use. Tapering, discontinuation can be considered after 3 to 6 months if the symptoms are controlled. So it is not a progressive disease, it is a fluctuating disease. So after half a year, after a year, try to speak with your patient whether or not to stop these preventive, sometimes toxic drugs. The drug-to-drug interactions due to pharmacokinetics, due to elimination issues are very important to consider in patients with migraine who use multiple medications, multiple preventive medications. So what is wrong with the current prophylactic treatments like I just have listed and overviewed? The side effects of these drugs are a common concern with prophylactic migraine treatment. Antidepressants, for example, as you know, they cause dry mouth, constipation, sedation, weight gain. Beta blockers, they cause fatigue, nausea, reduced ability to sleep, to exercise, and give also depression. Calcium channel blockers, they may cause sedation, weight gain, cardiac effects, and hypotension. And of course, the anti-epileptic drugs, as valproate or topiramate, can give tremor, weight gain, language problems, and so on. In order to get less side effects, in a recent retrospective study, alternated doses of valproate were used of one day 250 milligrams and the other day 50 milligrams. So small studies here and there are looking for some ways how to improve the quality of life with less adverse events for those conventional prophylactic treatments. These alternating doses for valproate, for example, seem to be effective as the higher doses, but still they induce modest weight gain, but less other adverse events. However, here we see that the adverse events may discourage acceptance of prophylaxis, negatively influence the patient adherence, and result in non-regular daily dosing and lead to self-reduction of the prescribed dosage. More than 80% of patients with chronic migraine discontinued their prophylaxis treatment within 1 year. More than 80%, they just discontinue without letting you know in the consultation. So, how do we define the resistant, the refractory migraine? The debilitating headache is a headache with a serious impairment to conduct activities in daily living. The resistant headache happens to occur at least 3 months with an inadequate response to at least 3 attempts of drug treatments. Refractory headache is a headache which occurs at least 6 months where migraine cannot be managed with the maximal available treatments. The definition of drug failure is 2 months for oral drugs, 6 months for botulinum toxin, and 3 months for the CGRP antibodies. So we are talking in our headache center about resistant, refractory, chronic migraine, patients that cannot be helped anymore in the first line, in the second line, and are very confronted with the unmet needs like we have mentioned in the introduction of this talk. So no meaningful reduction in headache frequency after administration of drugs for at least 2 to 3 months, as recommended by the European Headache Federation treatment guidelines at generally accepted therapeutic doses. This is a treatment failure. So what is galcanezumab? What are the CGRP monoclonal antibodies? Galcanezumab is a humanized immunoglobulin monoclonal antibody. It is designed to target the CGRP with high affinity, with high specificity. It binds the CGRP and prevents its biological activity without blocking the CGRP receptor. It is thought to act peripherally in structures involved in migraine headache pathogenesis, including trigeminal ganglia. The development of these migraine-specific, evidence-based preventive treatments allows for a very tailored clinical management that reduces the risk of drug-to-drug interactions and associated adverse events in patients with comorbidity. Recent studies sponsored by Eli Lilly conclude that patients on those CGRP monoclonal antibodies were more likely to be adherent and persistent compared to patients on non-CGRP monoclonal antibodies. This is the reason why I mentioned this curve. The CGRP monoclonal antibodies, they bring another world. They bring a new era in the prophylactic treatment of episodic and chronic migraine. Galcanezumab is indicated for the preventive and the chronic migraine in adults. I told you before about the pivotal trials. An example of these pivotal trials for galcanezumab are the EVOLVE-1 and the EVOLVE-2 trials. All of these drugs, also erenumab, also fremonizumab, they have their pivotal trials. EVOLVE-1 and EVOLVE-2, as an example, were 6-month, phase 3, multi-center, randomized, double-blind, placebo-controlled trials. Patients meeting the ICHD criteria for diagnosis of migraine, they could still continue their acute medications. They should not have failed 3 or more classes of preventive drugs. They were included in a randomization of placebo or galcanezumab 120 milligrams per month with a loading dose of 240, or once monthly galcanezumab 240 milligram. There were primary endpoints, as I told you before. It's the mean change from baseline of monthly migraine headache days over month 1 to 6. There are also the key secondary endpoints, which are the response rate, which are the overall mean change from baseline in monthly migraine headache days with use of acute medication, and of course, which are increasing the daily functional activities, which are making functional activity much better and much more easy. So these are the in and the exclusion criteria, the treatment arms, and the clinical endpoints of the pivotal trials of galcanezumab. It means that of those trials, the results are used to get approval of these new prophylactic drugs. You have to know that galcanezumab is approved 240 milligram as a loading dose. It is not recommended for maintenance because it showed no additional benefit over galcanezumab 120. But as a loading dose of 240, it is approved. So here are the results. The primary objective was met for both galcanezumab doses. Treatment with galcanezumab significantly reduced monthly migraine headache days by 4.7 days. 4.7 days in the 120 and 4.6 days in the 240 milligram compared with placebo. Placebo was 2.8 days. There were no meaningful differences between 120 and 240 milligram doses on measures of efficacy. The difference, by the way, between EVOLVE-1 and EVOLVE-2 is where the population or where the population to study has been recruited. EVOLVE-1 was in America, and EVOLVE-2 was worldwide, America, Europe, and other regions. This is the only difference between EVOLVE-1 and EVOLVE-2. So when reviewing these results, we know that galcanezumab separated from placebo at each month. We got this huge significant difference from month 1 to month 6. So already in the first month, we see a clear difference between the galcanezumab treated group and the placebo treated group. Response refers to % reduction from baseline in monthly migraine headache days. Here we are evaluating the decrease of migraine headache days. Here we are evaluating the response rates, response rates in the reduction of mean monthly migraine headache days versus placebo. Instead of the absolute number of monthly migraine days decrease, the effect for an individual patient can be as clearly explained with the response rates. And here are the response rate data from the EVOLVE-1 and EVOLVE-2 trials. The response rates are the mean percentages of patients reaching at least 50%, 75%, and 100% reduction from baseline in the number of monthly migraine headache days over the 6-month treatment period. So we know that the data are over months 1 to 6. There are not a lot of long-term data yet. The percentages in each bar represent the mean of the percentage of the patients who achieved at least 50%, at least 75%, or 100% reduction in migraine headache days versus baseline at each single month. We mentioned that the minority of the patients is super responder with no migraines at all because of the medical treatment, which means they have no migraine headache days due to treatment. But this is a minority. Do not tell your patients that the migraines will completely disappear with the CGRP monoclonal antibody treatment. Only a minority will have this result. However, we conclude that galcanezumab is a very good agent with high investigated 75% and 100% response rates. Remember the criteria of medication overuse. We were talking about it at the end of the topic about acute treatment for migraine. Remember how medication overuse expresses the burden of disease for a patient. We review in this slide the mean reduction in monthly migraine headache days with acute medication that was used in EVOLVE-1 and EVOLVE-2 trials. Again, the data are over months 1 to 6. In EVOLVE-1, the mean number of monthly migraine headache days that acute medication was used at baseline was 7.4 in the Emgality 120, 7.4 in the placebo group. In EVOLVE-2, again 7.5 versus 7.6 at baseline. So the Emgality 120 milligram treatment groups demonstrated a much greater reduction in the number of monthly migraine headache days that acute medication was used compared with the placebo groups. Galcanezumab has been studied as prophylaxis for chronic migraine in the REGAIN study. So we have EVOLVE for the episodic migraine, the REGAIN is for the chronic migraine. The mean number of monthly migraine headache days at baseline was 19.4 for the total sample. Both galcanezumab dose groups in red and in blue on the screen demonstrated greater overall mean reduction in the number of monthly migraine headache days compared to the black placebo. Placebo was minus 2.7, galcanezumab 120 was minus 4.8, 240 minus 4.6 days. So the authors of the REGAIN study conclude that both doses of galcanezumab were superior to placebo in reducing the number of monthly migraine headache days in the patients with chronic migraine. Galcanezumab appears efficacious, safe, and well tolerated for the preventive treatment for chronic migraine. A reduction in migraine headache days at each month was statistically greater in both calcanezumab dose groups compared with placebo. In each month, you see here, month 1, month 2, month 3. There is in each month a significantly greater reduction for calcanezumab compared to placebo. Again, there are the response rates. The response refers to the percent reduction from baseline in monthly migraine headache days. Differences between calcanezumab doses were not significant, but we mentioned that the minority of the patients, even with chronic migraine, is a super responder, which means that they have no migraine headaches at all due to this CGRP monoclonal antibody treatment. But this is a minority. So again, we are talking about resistant refractory migraine. Because of this resistant refractory migraine, we were looking for the CGRP monoclonal antibodies. Okay, are those CGRP monoclonal antibodies really helpful in the patients who already failed 3 or more other preventive drugs? This is a short conclusion of the CONQUER study, where Emgality has proven to be an option for refractory patients. We summarize the CONQUER study. Many patients who require migraine preventive treatments have not been able to tolerate or have not responded to multiple previous preventive medications. So the CONQUER study aimed to assess the safety and the efficacy of calcanezumab over a period of 3 months. The primary endpoint was again the overall mean change from baseline and number of monthly migraine headache days during the 3-month period in all patients who were randomly assigned and received at least 1 dose of the study drug. The CONQUER study concluded that calcanezumab was superior to placebo in the preventive treatment of migraine and was safe and well tolerated in patients for whom multiple previous standard of care preventive treatments had failed. Calcanezumab might represent an important treatment option for patients who have not benefited from or tolerated previous standard of care treatments. So whether there is a failure because of adverse events, whether there is a failure because of lack of efficacy, for both groups, for both kinds of failures, calcanezumab and the other CGRP monoclonal antibodies might help those patients as a rescue of their chronic headache disorder. What are the guidelines about these CGRP monoclonal antibodies? Well, recommended preventive treatments by for example, the British Association for Study of Headache for episodic and chronic migraines are amitriptyline, propranolol, topiramate, and then the CGRP monoclonal antibodies. For chronic migraine, we are talking about onabotulinum toxin type A, which is recommended as well. So here we are going to a difference between episodic and chronic migraine. Some countries, they will reimburse the CGRP monoclonal antibodies for both conditions. Some are only reimbursing yet for chronic migraine, while a 5 for episodic migraine has still to be prepared by the pharmaceutical companies. So this depends from one country to another. The United Kingdom NICE guidelines recommend the monoclonal antibodies recommended for patients who have 4 or more migraine days a month. The treatment options for preventing episodic or chronic migraine include, as I told you, beta blockers, antidepressants, and anticonvulsant drugs. If episodic migraine does not respond to at least several preventive drug treatments, the best supportive care has been offered. If chronic migraine does not respond to 3 oral preventive drug treatments and botulinum toxin type A, the best supportive care is offered. For migraine that has not responded to 3 preventive treatments, clinical trial evidence shows that calcanezumab works better than best supportive care in both episodic and chronic migraine. So the European Headache Federation expert opinion, so this is not a randomized trial, this is an expert opinion on the use of CGRP antagonists in episodic migraine and chronic migraine, answers following questions. When should the CGRP antagonists be offered? The answer, Erinumab, fremanezumab, or galcanezumab are recommended in patients with episodic or chronic migraine who have failed 2 or more available medical treatments, or who cannot use other preventive treatments because of comorbidities. Second, how should other preventive medications be managed when using CGRP antagonists? Is there any place for co-medication? For episodic migraine, they advise to stop oral preventive medications before initiation of the CGRP antagonists. For chronic migraine, we could add CGRP antagonists and consider later withdrawal of the existing drug. They advise to stop onabotulinum toxin A before initiation. Here I want to give a very short comment. I referred in the beginning pathophysiology to the A delta fibers and the C fibers. Bernstein from the United States, he has cleared out that botulinum toxin is more working on the C fibers, while the CGRP monoclonal antibodies are in rats, in animals, more working on the A delta fibers. So why could there not be an agonistic effect of botulinum toxin combined with the CGRP antibody? Of course, there are a lot of reasons why we should not do this in all patients with chronic migraine. One of the reasons is the lack of evidence in humans. Another important reason is, of course, the healthcare cost if you combine 2 quite expensive preventive drugs. The third question, when should CGRP antagonists be stopped? After 6 to 12 months in episodic migraine and chronic migraine. I think that a lot of doctors, a lot of professionals strongly disagree with these 6 or 12 months. When a patient is really very grateful for this major help that the patient got from these newer drugs, from this new preventive era in migraine, okay, we cannot stop it very easily after 6 to 12 months. However, this is their advice. Should medication overuse be stopped before initiation of the CGRP antagonist? A very interesting discussion where there are very important cultural differences between northern Anglo-Saxon Europe and the more southern Mediterranean countries. In chronic migraine, use before or after withdrawal of acute medications is advised. In which patients should CGRP antagonists not be used? We avoid them in pregnancy or nursing mothers. When a young lady stops her anticonceptive drugs, she has to stop the CGRP antagonist before getting pregnant. In people with alcohol or drug abuse, with cerebrovascular diseases and other severe immunological disorders, we are not advising to take those CGRP antagonists. Should binding and or neutralizing antibodies be monitored? For this small amount of monoclonal antibody that we are injecting, we should not monitor in daily clinical practice. So very important is the patient-reported outcomes. Although most migraineurs do not have a formal diagnosis of a mood disorder, more than half of the participants in the studies reported that migraine had a very negative impact on their emotional health beyond typical psychiatric diagnoses such as depression and anxiety. Factors outside the migraine attacks, such as fear for the next attack, avoidance behaviors leading to life restrictions, are major contributors to poor quality of life. So during your consult with the migraineur, the question, how does migraine impact your life, serves a lot of purposes. And please ask this question to the young and older migraineurs, because this question, how does migraine impact your life, increase the provider's holistic understanding of the disease impact on the patient. Second, this question provides an opportunity for the patient to acknowledge and express his or her perspective. What is the patient expecting from you in the consultation? Perhaps not only medication. And third, this question, how does migraine impact your life, improves the patient-provider communication. Patient-reported outcome data are essential for quantifying the treatment effect on migraine severity and the quality of life of the patient. So one of these scales is the migraine-specific quality of life questionnaire, which is a self-administered instrument to address physical and emotional limitations in people with migraine. The scale describes the frequency, the duration, the severity of the symptoms, and the disability of the attacks. It is a very reliable instrument in the assessment of quality of life for patients with migraine, with items that can be summed without weights. In the galcanism clinical trials, for example, the impact of migraine on daily activities was assessed by the role function restrictive domain in this MSQ. In this role function restrictive domain, 7 questions were asked about: work, relationship, leisure, productivity, concentration, energy, tiredness. So here are the results. There is a significant improvement in the quality of life assessed by the scale role function restrictive part. We discuss the effect of galcanism on daily activities in Evolve 1 and Evolve 2. And when we review these graphs, we note that the effect of quality on quality of life as assessed by this scale is observed starting from the first month of treatment. Impact of migraine on daily activities was significantly reduced with galcanism versus placebo through 6 months of treatment. Another instrument is the Migraine Disability Scale, or MIDAS. It measures the impact of migraine on everyday life. How many work, school days were missed? How many social activities did you cancel? How is your productivity affected? The MIDAS, the Migraine Disability Scale, is a patient-rated scale that was designed to quantify those headache-related disability over a 3-month period. It's easy to hand over this scale to the patients in your waiting room and just to fill in before they come on the consultation. And if they fill in different consultations, you can follow up how the disability in daily life is improving or is remaining the same. This instrument consists of 5 items that reflect the number of days reported as missing or with reduced productivity at work, home, and social events. So the migraine-related disability after the scale may be derived from this total MIDAS score, with scores between 0 and 5 for mild or infrequent disability, 6 to 10 for moderate, 11 to 20 for severe disability. And based on the scores, we have the graphs of clinically meaningful reduction of disability with the migraine disability score. We review the more than 50% responder analysis for Evolve 1 and Evolve 2 as measured by this total score. The response was defined as a 50% improvement from baseline in the MIDAS total score. Up to 80% of the patients on Emgality saw their overall disability cut in half versus up to 56% for placebo at month 6. So now let's come to the last part of the lecture, of the talk, the adverse events, serious adverse events during the treatment with monoclonal antibodies. Former preventive drugs are used for many years as prophylaxis for migraine. There is a good knowledge about possible short-term and long-term side effects. We discussed all these before, and also in comparison with the adherence to these former drugs. The CGRP monoclonal antibodies, they are new, and studies, they have a follow-up of no longer than 5 years. So what is known so far about the possible side effects and about the long-term possible side effects? The Evolve trials conclude that galcanezumab 120 milligram and 240 milligram monthly injections provided clinical benefits and improved functioning in episodic migraine. But very important, the incidence rate of adverse events for episodic migraine was very low, demonstrating the favorable tolerability profile of galcanezumab. But also in the REGAIN trial for chronic migraine, there were no clinically meaningful differences between galcanezumab doses and placebo on any safety or tolerability outcome. except for a higher incidence of treatment-emergent injection site reaction relative to placebo. So CGRP, this is a slide I showed before, is widely expressed throughout the body, participating not only in pathophysiological conditions, but also in several physiological processes and homeostatic responses during the pathophysiological events. So there can be maybe possible long-term side effects. Although CGRP is expressed in multiple body systems, the trials to date have demonstrated minimal adverse events. Studies with all the monoclonal antibodies demonstrated a good safety profile. Common adverse events are injection site reactions, pain, upper respiratory tract infections, but very low incidence, not significant. The incidences were similar between the active treatment groups and placebo. The risks, however, of long-term blockade of the CGRP pathway are discussed with focus on the cardiovascular system, as this peptide has been described to have a protective role during ischemic events. So if we block this peptide, what will happen with our cardiovascular system? In the migraine patients, they present a higher risk of stroke and myocardial infarction. So here I have a copy of the cardiovascular safety profile of fremanizumab, the other CGRP monoclonal antibody, in patients with migraine and cardiovascular medical history or risk factors: hypertension, palpitations, blood pressure, heart rate, tachycardia, hypotension, and so on. But you see that the incidence of those cardiovascular events of the pooled analysis is very low for quarterly fremanizumab, for monthly fremanizumab versus placebo. Hypertension was the most commonly reported adverse event across treatment groups. But recent study published during the European Headache Federation conference showed that fremanizumab is merely inducing hypotension. So it's not very significant, all those cardiovascular side effects so far. No safety signals were identified in this study. Fremanizumab has a favorable safety profile, even in patients with cardiovascular medical history or more than 2 cardiovascular risk factors. So these are the safety results, not for fremanizumab, but for galcanezumab, the results of EVOLVE-2. On the right, we see the treatment-emergent adverse events. The injection site pain was the most common treatment-emergent adverse event, reported at similar rates in all treatment groups. Both doses of galcanezumab had significantly more injection site reactions and injection site pruritus, some kind of itching. And the 240 milligram group had significantly more injection site erythema versus placebo. But on the left is the frequency of serious adverse events, which is very low and not significantly higher for galcanezumab compared to placebo. So the authors conclude that galcanezumab 120 or 240 milligrams given once in a month was not only efficacious, but also safe and well tolerated. So the injection site reactions are the only adverse reactions occurring in adults with migraine with an incidence of at least 2% for Emgality, at least 2% greater than placebo in episodic and chronic migraine in the double-blind studies. The injection site reactions are erythema or induration. The incidence of discontinuation due to those adverse events and due to the serious adverse events are very low, or as low in the galcanezumab group as in the placebo group. So another small question that I want to ask myself, I want to ask you, what do you think about the wearing off phenomenon occurring with the CGRP monoclonal antibodies? I mean, the dose is once in a month, but maybe after 3 weeks, patients say like, okay, my migraines are coming back. Patients who trial a CGRP monoclonal antibody, they may experience a wear-off phenomenon that is equal to approximately 25% of the anticipated time of therapeutic benefit, which means a meaning of after 22 days of the month. Clinicians may consider documenting the use and benefit of some kind of bridge therapy for this wearing off period. but further research on larger scale is needed to gain additional insight into the presence of CGRP monoclonal antibodies wearing off phenomena, about the potential differences in wear off by CGRP monoclonal antibody medication type, and recommended next steps of treatment, what to do with this kind of wearing off. This is to study further on. So I would like to conclude with some summary. What patient is most eligible for a treatment with a CGRP monoclonal antibody or for a CGRP receptor monoclonal antibody? What patient is most eligible to start a treatment like with calcanismab? For example, a young lady with a long history of migraine who adapted already her lifestyle, who failed a couple of preventive treatments, and still she has a huge burden of disease because of too many migraine headaches per month. Acute treatments are not successful in controlling the migraines. Why Emgality is a good prophylaxis? We start with 2 doses for a fast onset of action, as well as the other CGRP maps. They have a fast onset of action within first weeks, within first month. The treatment should be repeated with the CGRP monoclonal antibodies once a month, 1 dose. Maybe the patient will be a super responder, but at least there is a huge chance that she will be a 50 or a 75% responder. So there is a proven efficacy in episodic and chronic migraine, including for the treatment-resistant patients. There is an early, but also a sustained effect that has been proven in the pivotal and in the long-term trials for the CGRP monoclonal antibodies. Because of the loading dose with calcanismab, well, let us not wait for the therapeutic effect to be seen. It will be seen as well in the first days and in the first weeks. With Emgality, we expect a fast and a highly effective result for this patient. Treatment with calcanismab resulted in an annual indirect costs less in patients with episodic migraine or chronic migraine across the regions. So the healthcare costs will become less because of good preventive treatment. Last sentences, optimally using the expanding therapeutic armamentarium requires a holistic approach and a very balanced understanding of the distinct ways in which migraine impacts our patient's life. I explain, I think that those new treatments, they help us to push the reset button in the computer to push back the pathways, the pain pathways, but meanwhile, the patient should be helped in a holistic understanding and a holistic treatment plan. Thank you very much for your attention, and I'm very curious about the next upcoming discussion. Thank you very much.
Thank you, Professor Pascal, for this comprehensive presentation. I guess you touched everything, and I will let Dr. Ramis to take the questions from the audience. I guess still I can't see any. Can you see, Ramis, any questions?
No, I don't see any questions yet, but maybe I can ask Dr. Prout a question that you mentioned during the talk about resistant, refractory, and debilitating headaches, and you had definitions for each of them. And are these definitions widely accepted or operational to divide patients? Because again, we keep being asked which class of patients is most suitable for anti-CGRPs. So is there one of these class that we would go for right away with anti-CGRPs and others that you would start other preventives until then?
Mm-hmm. The definitions of resistant and refractory are not invented by myself. I took them from a presentation that I heard in the recent European Headache Federation. It was one of the presentations during the lectures about guidelines and about how to give interpretation to the guidelines. I think that the difference between resistant and refractory migraine is very interesting because, of course, you want to put your patient in your file in a certain kind of group of patients. Whatever, when we come to guidelines about prescribing the CGRP monoclonal antibodies, there is no clear difference made between resistant, whether the patient is resistant or whether the patient is refractory or whether the patient has just failures and so on. It's all about the same, that patients are having very high unmet needs after having taken several of the former preventive treatment drugs. And so, depending, of course, on the countries, we always have 2 to 3 to 4 failures that have been submitted before prescribing the CGRP monoclonal antibody. I think this is right. We have much more experience with the older treatment, with the proven drugs. The older proven drugs are much cheaper, and they have proven to be effective. So, of course, it's right to start with those treatments before prescribing the CGRP monoclonal antibodies. I compare it a bit with a student of 23 who gets his first car. It will not be a Porsche, it will not be a Mercedes. Of course, Mercedes is very comfortable and it's very safe on the busy traffic of Cairo, I can imagine. But whatever, we will start with a small car. We will start with something very cheap and what is very accessible to all patients with migraine. And then later on, for those who are really refractory and resistant, we can consider the CGRP monoclonal antibody.
Please.
Okay. Common, or at least it's sometimes you will find a mixed type of headache with tension headache and migraine. And does this affect your decision about giving CGRP, or does this affect the outcome?
You mean the difference between migraine and tension type headache?
No, I mean, sometimes you have mixed. You have patients with mixed migraine and tension headache. Of course, you will give some treatment for tension headache as well as the migraine. But does this affect your decision regarding giving CGRP or not, or does this affect the long-term prognosis of those cases?
I want to do the best for my patients. So I want them to give the best treatments. Of course, according to the rules of our countries, Netherlands or Belgium. So if the rules are to first start some other preventive treatments, I will do. But whenever the patient reports some side effects, some adverse events, I will switch to a better treatment. Concerning the diagnosis, of course, a lot of those patients, they have a combination of migraine, and they fulfill also the criteria of tension type headache. When you do a very good medical history, I think that a lot of patients with tension type headache have as well those bothersome symptoms of migraine, and maybe there is photophobia or phonophobia all days of their headache. So I think that a lot of those patients with combination of migraine and tension type headaches are chronic migraines. This is my proper experience. So I think a lot of those patients could merit with a treatment for chronic migraine, with a prophylactic treatment for chronic migraine. Of course, if there is a subsequent continuous headache compatible with tension type headache, again, the holistic approach with cognitive behavioral therapy, with meditation is very important in the global medical treatment plan. And this is why we work together with psychologists. This is why we work together with physiotherapists in our headache center.
Thank you.
Great. I don't think we have other questions at the moment, but maybe at the end of the session we'll see if more questions are coming in.
So I guess Ramez, you will present a case now?
Yeah, okay. I can do the presentation now. I'll share my screen.
And please, for the audience, if you have any question for Dr. Pascal or Dr. Ramez, of course, when he presents his case, please put it in the chat or Q&A.
Okay, so thank you again for your attention. And this is a case presentation about a pain case. As you know, our kind sponsor for this event is Eva, Lily, And of course, there is the headache and also the pain. And also our chapter is involved in both of these areas, headache and pain. So it's a quick case and it's open for discussion. And I'll just go through it in a few minutes and then we can discuss what to do about it. So this is a female patient, 44 years old. And this patient in 2014, when she was only 37 years old, she had a massive stroke. This stroke was during or right after knee surgery for a trauma. And there was suspected DVT after the knee surgery. And then it was found that she has patent foramen ovale. And unfortunately, she had a massive stroke after the knee surgery, 1 day after the knee surgery. Her past medical history is only significant for migraines, which she had since she was in her teens, but no other history of note, and she is not known to have any thrombophilias or other medical problems. So this is the infarct she had, the stroke she had. It was quite large in the MCA territory. It left her with right-sided weakness and hemihypothesia, and also with residual aphasia. So as you can see, there is a large territorial infarction in the MCA territory. This is, of course, an MRI after the event, so it shows the area that was affected. Over the next 2 years, the patient had extensive rehab, and the rehab actually was very successful. She had the combination of physiotherapy, repetitive transcranial magnetic stimulation, cognitive and speech rehab sessions, and she improved very, very well. But of course, it took 2 years to get to that point. Her weakness was almost completely gone. She used to go windsurfing, and actually after 2 years, she was able to start windsurfing again. And as you all know, windsurfing is very demanding, but she was able to do it after 2 years. She had an occasional complaint of right-sided spasticity. She would say that the right side does not feel very normal, but of course, since she could windsurf, the complaint was considered that very subjective problem. She still has aphasia, but can hold a conversation with difficulty in vocabulary, but can text over the phone and can have a conversation in both English and Arabic, and has resumed work at an insurance company. And her regular medications are only aspirin and sertraline. Sertraline she started after the event because of depression and has continued on it since then. So in 2016, that's again 2 years after her event, she started to complain of gradually increasing pain and paresthesias on the right side of the body, the side that was affected by the infarct, and her migraines were increasing in frequency. We did a repeat MRI of the brain, and there was nothing new, with full recanalization of all her arteries and no new lesions. A trial of carbamazepine and amitriptyline were not helpful. So duloxetine was added to her treatment. This caused some improvement. So duloxetine, in addition to her sertraline and the aspirin, this improved. And we assumed that this was central pain because of her stroke, part of the residual symptoms of stroke. Recently, she stopped the duloxetine 2 years ago, and recently she presented with acute left-sided sciatic pain. So sciatic pain, she is still windsurfing, and she came back from the windsurfing a few weeks ago with acute left-sided sciatic pain. She had also an increase in the right-sided paresthesias and pain. And we did a new MRI of the spine, of the lumbar spine, and also the cervical spine to see what the right-sided paresthesias and pains could be. So this is the images of her lumbar MRI, and you could see she has protrusions of several of the lumbar intervertebral discs, especially the upper ones rather than the lower ones, so L12 and L34. But more importantly, in the neck MRI, there is quite significant protrusions of the cervical intervertebral discs, and these are touching the cord and indenting the cord. So this is a close-up of the sagittal MRI, T2. And as you can see, there are at least two significant disc protrusions indenting the cord, and you can see some change in the cord signal opposite the indentation in one of the sections. So the discussion should be, or could be, what would you do? Would you go back to duloxetine? Would you do a neck intervention like surgery or injections or so? Would you do an intervention for her lumbar sciatic pain? Or would you give steroids? So this is open for discussion, of course, for the panelists and for the attendees if they also want to contribute. So thank you very much. I will keep it on this slide, and you can share in this if you want. So Professor Hani.
Okay. Still, I guess I can see 4 questions. Have you seen any questions, more questions, Ramiz?
No, not on my side. No.
It's an interesting case anyway.
Okay, so I think this, yeah, maybe I got some questions here for Dr. Prout. Okay, so yeah, other than Midas MSQ scale, kindly tell me frequently used scales in migraine.
I think the scales in migraine, they are very diverse. There are several scales, and I did not want to mention too many scales for a couple of reasons. First of all, I wanted to relate the scales to the functional disability of the patients and how they are incorporated in the medical trials for calcanezumab. So these were the 2 scales that were extensively measured. Second, and I mentioned it for short, is that of course we can use one or other scales in daily clinic, but I see that sometimes the results of the scales are outweighing the real benefits that we can get with the scales. I explain. A patient needs attention. A patient comes to the doctor with a very chronic migraine and has a lot of difficulties to live together with his chronic migraine, with his chronic headache. And this is the reason why the patient gives the highest scores on disability, and it's very difficult to evaluate progress in the scales. So we are very happy that some data are about the patient-reported outcomes, but however, it's still difficult to implement them in your daily practice. So this is the reason why I did not comment on too many of these headache scales.
Okay, yeah, but frequently used ones, so of course, Midas.
The frequently used ones is, for me, is the Midas, is the migraine disability headache scales, and also the HIT score, the headache impact test, which is a score of 5 or 6 questions. It's very easy. But the problem with the Midas, for example, is that the score is immediately very high. It's like the patient has a very large burden of disease, and it's very difficult to get a score of only 20 or only 25. They have immediately a score of 40, 60. So very difficult to see any evaluation in a good way, any progression of the functional disability based on the MIDAS. Maybe the HIT6 is sometimes a little better, but the HIT6 is not covering the whole functional disability. But of course, those two scales are very easy to ask the patients, and they can complete it in a few seconds or in half a minute.
All right. There's another question for you from Dr. Nagarajan. Says cost is most frequent problem while using drugs or injections like erinumab and veltulizumab. So how do you get around this? Of course, it's the problem everywhere of reimbursement. And I think you mentioned that it is started to be reimbursed in Belgium. Is that right?
Yes. So first of all, yes, in Belgium it is reimbursed under certain conditions. Since a couple of months, there should be a couple of failures, and the patient should have a chronic or a highly frequent episodic migraine. In the other country where I work, in the Netherlands, it will be reimbursed soon, but so far there is a very huge medical need program that is running for the 3 of the CGRP monoclonal antibodies. From medical need program means that the company is sponsoring. I don't know if you are familiar with this kind of programs before reimbursement. Whatever, those drugs are expensive. But in the case that we would not have these drugs, in the case that there would not be a large scientific interest in the treatment plans for chronic headache, the healthcare cost would be very high as well, because the patients, they are overtaking over-the-counter medications, they are overtaking other preventive medications, they have a higher frequency of needed follow-up consultations with the doctor, with the neurologist, they have a higher emergency department visit, and this as well brings a lot or a big deal to the healthcare cost. So I think, yes, the medication is expensive, but oh my God, the economical burden of disease will decrease very soon. The patient will feel better at home, towards the children, towards the partner. The patient will feel better in professional life. So thanks God that this medication exists. And also the patient will have less follow-ups needed with the headache nurse or with the neurologist. So the neurologist will have more time, more place for newer patients. And so there will be a higher access, not only to the medication, but also a higher access for better prevention and better education of a bigger range of migraineurs, of migraine patients.
Great, thank you. Okay, and finally, what do you think we should do with the case we presented?
Mm-hmm. Well, I think you did a big trial with good drugs to treat these neuropathic pains. I think for, again, also these chronic pains, it's very important to combine good medical practice and the best medical practice tailored for that patient, individualized for that patient. So to switch from one drugs to another, I'm used to duloxetine as well. I think it's a very good drug for neuropathic pain. But of course, living together with a chronic pain is not just taking medicine. It's living together with a very unfamiliar guest who is sitting there the whole evening at the table. So imagine that you are going to a party, but there's one friend or one nephew that you really cannot tolerate, but he's sitting there at the other side of the table. What you're going to do? You're going to say, okay, my evening is gone. There's no pleasure anymore. Or you're going to say, okay, leave this boy there, and I have my territory. I have my space. So this is a small story to example how patients should live together with this uninvited guest, together with this unlikely guest throughout their whole life. So it's not only about taking the medication, but it's finding a way to have a very good, comfortable life as well, together to live with this chronic pain syndrome, whether it is neuropathic pain, whether it is other pain. So in this living together with chronic pain, I think there's a big place for ACT, acceptance commitment therapy, which means integrating your values, your most beloved values in your life within the life lived together with the chronic pain syndrome. It is accepting the chronic pain, accepting this guest that you dislike at all, but accepting it as something you have to live with in your daily life. And this goes perfectly together with all the trials, with all the individualized medical treatment that you suggested.
All right, great. Thank you very much.
I guess we don't have any more questions, Rams. I don't have in the chat or on the...
No, I think that's all, yes.
Okay. So if there is no more questions, we'd like...
I'm sorry. There's one more question that just came in last minute, and I think that's the final question. What effective drug do you use for migraine patients during pregnancy? Okay. Very common question, a very difficult question, I know. But yeah.
First of all, the course of the migraine will be different during the pregnancy. However, even if you can predispose that migraine will be less during pregnancy, there are still some patients who have a high frequency of disturbing migraines during the pregnancy. As acute treatment, as abortive treatment, we use paracetamol or acetaminophen, or we can use sometimes a triptan if it's really needed. But triptans are not completely prohibited during pregnancy. As preventive treatment, I would like to use a combination of riboflavin. Riboflavin is vitamin B2, 2 capsules of 250 milligrams a day. It's 500 milligrams a day, which gives no side effects except of yellow urines, but further there are no side effects, and it can decrease the headache frequency and the headache intensity. Of course, the other treatments are not done, are not given. No beta blockers, no anti-epileptic drugs, and for sure, no CGRP antagonists during pregnancy. But again, together with the medical treatment, please focus on living together with the headache frequency, on living together with the burden of disease, and try to find a good combination with physiotherapy, with physical therapy, with medication, and cognitive behavioral therapy.
Right, great.
That's great. So I guess at the end, we would like to thank our dear guest, Professor Pascal, and thank you, of course, Dr. Rams, for inviting and let us know the very eminent speaker, Professor Pascal from Belgium and Netherlands. And we hope next time we will meet face-to-face physically, hopefully next year.
It was my pleasure to speak for you. It was my pleasure to answer the questions, and I think that we should continue this kind of headache education, not only for our own profit, for our own clinic, but as well for the big amount of migraineurs throughout the world who really suffer because of their chronic headache disorder. So let's continue this education. It can be online, but it would be very fine to meet each other sooner or later in Cairo or somewhere in Egypt.
Yeah. And I will remind also our dear audience that the next 3 waves will be multiple sclerosis, and we have so eminent, also very eminent speakers. Next time we will have Alex Rovera from Spain, and we will have the next waves, Martin Touré and Martina Abstina, and many of our eminent speakers. And we hope that you will get benefit from this continuous educational program, hopefully. So bye for now, and see you next week.
Thank you very much.
Bye-bye.
Thank you. Bye-bye.